So these guys got the world's record. It's an unusual distinction here. So, a patient comes in and says, "Doctor, I think I'm having a stroke." And you say, "Are you, what are your symptoms?" So my face is all drooping here and my speech is a little messed up, but my arm and legs move just fine. Thank you very much. The key here is this person can not move their forehead. If you can't move your forehead, then this is a peripheral seventh nerve issue. The issue is behind the back in the brain or peripheral seventh nerve, and we see it all the time. Patients are very frightened by it. I don't blame them, and they want your reassurance, and so you have to confidently know that this is what the problem is. And they can't close their eye very well, and they don't have the strength to do that. Those are the two biggies. And we try to figure out, well, what could possibly be causing this kind of thing? And here's the list. We think that herpes is a potential cause. And those of you who live in the Northeast, everybody knows that the first thing that you think of is Lyme disease as the cause of this. And otitis media, in the ENT world, the ear and the seventh nerve are really close friends. Stuff that happens in the ear can affect the seventh nerve, resulting in a peripheral paralysis like this. What is the cause of Bell's palsy? We don't know. To be technically accurate, Bell's palsy is that term is used when you don't know the cause. But we do try to find the cause. If you have a Bell's palsy case, the literature says that most of it goes away, but not all of it, and it's frightening, and it takes a while for it to go away. And in some cases, it doesn't go away. I don't know if remember Ralph Nader? Ralph Nader's Bell's palsy never cleared up, and he had a drooping face for the rest of his life. There is some, potentially nasty risk here. The treatment for you is to give steroids. A good slug. Here's 60 milligrams, kind of thing. Send them to the ENT doctor if they can trace why this nerve is being compromised, but definitely do that. The issue about acyclovir, that was the theory that, well, maybe they found that maybe there was some evidence of herpes virus around the seventh nerve, and so maybe that had some etiologic issue here, and well, maybe we should give some acyclovir. The literature is very clear on this. It does absolutely nothing. The nice thing about acyclovir is it's cheap. Cheap, but doesn't do anything. So get them their steroids. There's this issue about closing their eye when they sleep so they don't get dry eye out of this thing. That's Bell's palsy. Canada, we see this in little kiddies all the time. Mothers get a little freaked out. What is that white stuff there? It peels off pretty easily with a little tongue blade jobber, and then there's a reddish base, and you just tell mom that this is a fungus. The old and the young, basically, and particularly the old who have dentures that don't fit very well. The next thing this is one of the things that they can get out of that. Antibiotics, that's what we tell mom, that's one of the risks of being on antibiotics that you don't need. Diabetes, steroids, and HIV, these are all clustered in people who are immunocompromised. But to be candid, adult diabetics who are type 2, their immunocompromise is really marginal. They always get lumped in there. There's no comparison to diabetes with HIV or chemotherapy, for crying out loud. And there is nice treatment that we give people. We don't use gentian violet anymore. I always liked the gentian violet. Anything that bad looking had to be doing it good. Leukoplakia is one of those things where look in somebody's mouth, you get that white thing there in the back, generally around the dentures or over the teeth, and doesn't scrape off. Considered precancerous. You're doing a patient a big favor because you found this thing and say, okay, let's go. You're going to need to go to a doctor and get that biopsy kind of thing. Canker sores. We see these all the time, not in adults. They're not going to go to you for a canker sore, but they're going to bring their kids in. Their kids are miserable. They're crying. They're not eating, those kinds of things. I looked it up because I wanted to be really bright about this stuff, and I found out that abscess is Greek for ulcer. So these are ulcers. It's like, I don't get it. Anyway, you pull your lip down and you got this ulcer there and it's got a gray base and it hurts like hell kind of thing. And you might have 2 or 3 of them. we don't really know. We believe cell-mediated immune response to unknown trigger. Basically, we have no idea. But there is some nice treatment for it. Are you familiar with this drug here? Aflosol. Aflosol basically is a anesthetic, and it supposedly accelerates the healing of this, and it's by prescription. So if you got somebody, a little kid's got this, you want to give them something, here's a $30 prescription that you put it on 4 times a day onto these sores, and gives the mom some relief. And the kid, herpes simplex angioedema. This is, I don't feel so good for a couple of days, and then the next thing you know, there's a little malaise, maybe a little fever kind of thing, and then pop up one of these little blistery jobbers on your lip as the herpes simplex is activated here, and then you get this vesicles, and the vesicles break, and then you get a crusting over it. Then you get some secondary infection on top of that. And then it'll generally clear up, and the acyclovir products are kind of helpful in terms of lessening severity and duration. But then they go away, and somehow they know that you're under some stress or something like that, or you've been in the sun. Oh, the prom is coming up. The prom, let's put one of those sucker goombas right here, kind of thing. And the stressor of that causes these things to recur and recur and recur. Herpangina is an absolutely great diagnosis, and you'll make this diagnosis if you look into enough kids' mouths. This is a kid who comes in high fever, not eating, miserable kid kind of thing. It's during the summer, and you look into the kid's mouth, and you see all of these little ulcers on the soft palate and maybe on the tonsillar pillars, but that's the only place they are. They're not on the cheeks, they're not on the tongue, they're not on the lips, nothing. It's only allowed back there. They only signed the contract to get part of the mouth. And this is herpangina. It is painful. It will go away. Sometimes, and if the kids are old enough, there's this trick where you give them Benadryl elixir, and they swish that around in their mouth, and then they can spit it out. That's kind of one trick to do. You've heard of the cases where people would give them xylocaine elixir, and then you get into another problem where you're seizing with herpangina. Angioedema, this kind of crept up in here. I think it really belongs in another spot, but have you ever seen this come into the emergency department or your clinic? Once you do, it's like, we got a problem here. Angioedema is like hives, but it's deeper into the tissue and is not associated with itching. So this person's tongue is not itching. It tends to center on the tongue, the face, the hands, and of all places, the male genitalia. Why does it do the female genitalia? Somehow it knows, but it goes to the male genitalia. The idea here is that the common cause of this is ACE inhibitors. And ACE inhibitors, basically the whole world's on ACE inhibitors. It can happen anytime. It can happen the first day you take it, or 10 years into taking it, it's the ACE inhibitors. These things don't respond very well to the usual treatment with, epinephrine and steroids and antihistamines and that kind of stuff. It doesn't work very well. So you got to be aware that if this is progressing, that this may be a tough airway. There's another version of this, which is the hereditary version, which is not addressed on this slide, which I think you ought to know. So some of this runs in families. And in that case, it's a C1 esterase deficiency. And that enzyme can be reestablished if you give fresh frozen plasma. Fresh frozen plasma has it, but that works in the hereditary versions. I mean, if your back is against the wall, you might use it in this one kind of thing, but there generally are 2 varieties of angioedema. Everybody comes in with these things. I don't know, we tend to kind of poo-poo sore throats. What are you, sore throat, come on. Well, I tell you, have you ever had a strep throat? If you had a strep throat, you will never, ever poo-poo anybody again. Strep throat, you get 102, 103 fever, you have chills, myalgia, you are really, really feeling badly, you can barely swallow your spit, and somebody says, "You're here for a sore throat?" "Yeah, I'm here for a sore throat. It's really distressing me." The literature is basically in terms of the cause. We got strep, we got mono, we got epiglottitis and Lemierre's, and we're going to talk about those a little bit more. One of the things actually, here's a red flag kind of jobber. So sore throat pain on swallowing and a normal oropharyngal exam. You're looking at, I don't see anything. In those cases, and if the patient's got, yeah, it hurts like hell, and the voice is muffled, and this is an adult. When you look in the mouth, you haven't looked at where the pathology is. The pathology is down around the epiglottis, and we'll talk about that in a second. So here's the center score, center criteria. You get a point for fever, okay. I can tell you you're going to have a fever. You can't have a cold. You have no runny nose or cough. That's in there. Anterior nodes, okay, we got those. You got exudates on the tonsils. If you're under 15, you get an extra point. If you're over 45, if you're over 44, you lose a point. And the more points you have, the more likely it is that this is strep, and so that you could go ahead and just treat this person empirically with penicillin. Some people use Keflex-like drugs, and one of the reasons that they do that is that when penicillin doesn't do the job, the next drug that they use is Keflex because of these certain resistances. So some people say, well, screw it, I'll just use Keflex right from the beginning. This is a really dumb bug. It has not really mutated so that it basically is resistant to a lot of stuff. And in fact, the theory is that when you have a strep throat and the penicillin doesn't kill it, it's because you also had some other bugs in your throat elaborating beta-lactamase, which kind of took the penicillin out of the picture. So it wasn't the strep, it was the other bugs that are protecting the strep. So anyway, this is used, and this is kind of a reasonable thing to do. And this kind of tells you, basically, if you have a lot of points, treat. If you have no points, don't treat. And the whole issue becomes, well, what are the cases in the middle? Some people say that in the cases in the middle, you can use that quickie test, that quickie strep test. That if it's positive, treat. If it's negative, don't treat. If you're in a hospital, don't do that. If you're in a hospital, the hospitals are going to take that negative quickie test and then do a culture of the throat. And they're going to do that without even asking your permission. This is going to be automatically done. Why? Because every one of the quickie tests recommends that when the test is negative, you do a culture. And I know hospitals that have been cited by the Joint Commission for failure to do that culture. And ours was one of them. And it was like outrageous. What are you going to charge for that culture? $200 to do this culture? This is a $10 disease. You don't need a $200 test for a $10 disease. So the fact of the matter is that if you work in urgent care, you don't have to do it. The Joint Commission is not going to come around. And you can do what you want in terms of this thing. But the American Academy of Pediatrics also recommends this, that the negatives be cultured. It is a bad idea. Don't do it. This is the part about this. We talked about the treatment of this thing. Everybody's concerned about rheumatic fever. There's virtually no rheumatic fever in this country. There are occasionally little clusters. The routine strep that causes a strep throat is not the strep that causes rheumatic fever. You have to have the rheumatic strain that'll cause it, kind of thing. And you have 9 days to start treating this stuff with penicillin for 10 days to prevent it. So you don't have to necessarily nail this on the first day. And if you elect not to treat it and the person's still bothered with it and then you want to treat it then, no sweat. Obviously, you will not be protecting the person from glomerulonephritis because treatment of strep throats doesn't protect you from doing that. I think pills are fine for this. Some people give shots. I think giving a shot to a kid is a bad idea. If you can avoid it. It makes them hate the doctor. Have you ever seen a kid who is absolutely terrified of going to the doctor? They scream as soon as they hit the door. Well, obviously, they had a really very negative prior experience, and you don't need to. Treating a strep throat is not that big a deal. You don't have to treat it. I mean, in terms of penicillin treatment, it might relieve the sore throat by a day or a day and a half or something like that. You know, you're not going to buy a huge amount out of it. And obviously, these are self-resolving problems. It's not like I get a strep throat, and unless I get antibiotics, I'm going to die. No, so it's not that big a deal. Peritonsillar abscesses, you've seen these. I don't know whether you treat these. These are kind of, you know, you need to make local anesthetic. You need to make a hole back there with a leaven blade and have this stuff come out. And there's a big artery back there called the carotid artery. You know, you got to stay away from that generally. That's not a good way to flush out that abscess. So one of the things I saw recently was, you know, ENT doctors are kind of hard to find, and so we didn't. And so one hospital, the bigger hospital near us, called and asked our clerk whether we had an ENT doctor. The clerk said, yes, we did. She was wrong. We didn't have an ENT. So over comes a person with their MRI findings. They did an MRI for a peritonsillar abscess, but did nothing further. And over this person, I said, what are you thinking about? It's called a periton. There it is. You don't need a, oh, well, you know, it might go down a mediastinum kind of thing, cause it. Yeah, right, sure. So in any case, we didn't have one either, and we wound up having to treat this. Some of these, honestly, you can get away with aggressively treating them with antibiotics because, and the other thing is, you need to know whether there's pus there. So now they get that woman's vaginal probe, and they call it something else and stick it in your mouth. And if you see a pus pocket, well, then there's something to go after. But if you don't see a pus pocket, you don't want to be messing around with that thing. They also use that thing to kind of guide it. But that's a whole generation of, all the young people know how to do that. And I think it's fabulous that in these emergency medicine residencies, they know how to use an ultrasound. This stethoscope that's hanging around, that thing, that's going to leave. They're going to be all walking around the hospital with an ultrasound probe around your neck kind of thing in the near future. They can say, what's that? That's called a stethoscope. So here's a little bit on what you do in treating. Scarlet fever is a great little diagnosis. This is again, this is not the routine strep. You need a special strep to cause scarlet fever, but they get this sandpaper rash, and it's so characteristic that once you've seen it, you'll never miss that one again. And they get a strep throat too, and the tongue, they get a strawberry tongue with those little papules on there. Postheus lines, or they get the rash particularly in the folds. Mono. So these throats can look like the bottom of the bird cage. These can be the worst looking throats that you have ever seen. So these people come in, they got it from some kissing of another person, probably. They got the exudate down there. The key here is to, you know, normally you feel here for the sore throat. The key here is you feel back here. Posterior auricular nodes. You feel posterior auricular nodes and somebody's got a sore throat, the diagnosis is infectious mononucleosis. You can still get, you know, and then you have this issue of, we got to get a test, you know. All right, so the issue is, should I get a monospot? Or should I get a CBC? Or should I get both? That's the belt and suspenders approach. If you get a monospot, it's either black or white. It's just a positive, negative. So because of that, there's the potential for a false negative. If you get a CBC, you get to watch the gradual transition of the lymphocytes and say, you got a lot of lymphocytes there, more than you would be expecting, and the number gets higher and higher. And that really suggests, yeah, I think that this is probably mono. Even if, and they look at this in the slide and see if there's some what they call Downey cells there, which are characteristic of mono white cells. And so I think it's a good idea, particularly because, you know, this is a series of one. When I was in medical school, one day I did this, and it's like, what the hell is that? Is that my spleen? I felt my spleen, and it's like I felt well considering I was a medical student, and I said, I'm going to die. This is bad. This is bad. So I went to the head of dermatology at Temple University, where I was a medical student, and they looked at my blood. I said, look, you see any Downey cells down there? Because this test was negative, the monospot was negative. And I said, well, take a look. And see any Downey cells? He said, no, I don't see any Downy cells. I said, take a good look. You see any Downy cells down there? No. I went back a week later, looked at my blood again. See any Downy cells down there? No, not yet. White count's getting weirder and weirder and weirder. And finally, 3 weeks into this, the monospot turns positive. The blood was all screwed up. So that made it very clear to me that if I was going to get one test to determine whether I had mono or not, or you, it would be a CBC. It would not be a monospot. But in any case, we warned these people about no roughhousing kind of thing. We don't want to break your liver and spleen up, that kind of thing. And if you really want to make the diagnosis quickly, here's an ampicillin pill. You give them an ampicillin pill in the department, wait about 20 minutes, there you go. That's much faster in the lab. And when they break out in this rash, giving them an ampicillin pill was a mistake. And then you commit another sin by saying, never, ever, ever take penicillin for the rest of your life. Well, that's not a true allergic reaction. So you've committed 2 sins. You know, and they say, well, let's just cover you for some, let's just cover you. No antibiotics, no antibiotics. Lemierre Syndrome is, I don't know if you have seen this yet or heard about this, but this is cool. This is increasing in frequency. This is basically, you get a peritonsillar abscess. The peritonsillar abscess gets reinfected or co-infected with a bug called Fusobacterium necrophorium, nice name. Basically, and next thing you know, the internal jugular vein gets infected and gets a clogs in it, and there's a lot of pain in the side of the neck. It's unilateral pain, and the internal jugular vein starts shooting down into the lungs, these septic emboli, and so you take an X-ray, and they got these little abscesses all over the lung, and they are sicker than hell. So this is Lemierre Syndrome. You should be aware of it. You're not going to see it a lot, but if you see somebody with a sore throat, bad sore throat, unilateral neck pain, think of this disorder. Think of this disorder. Epiglottitis is basically a disease of adults now kind of thing. And this is the one where they come in with the muffled, the hot potato voice. Doctor, I got a problem here. And you look in and you don't see a damn thing because the problem is down below, around the epiglottis. And it's not just the epiglottis, it's all the periepiglottic tissues as well. So what you do here, and it's the same bug that caused it in kids, but the kids have been immunized, but you've not, and so it's H. influenza likely. One of the tricks here is to take the thyroid cartilage and move it right to left. If they jump off the gurney, when you move the thyroid cartilage right to left, the diagnosis is adult epiglottitis. And they get treated with ceftriaxone. Anything else on there? No. Cervical adenopathy. People come in, they might come into an urgent care center because of adenopathy. The real question is, doctor, is this cancer? So the 3 causes of cervical adenopathy that are kind of common is, number 1, you have some kind of infection that is draining into that node. So look through the hair and look behind the ears and try to find, if there's anything going on that might be draining into that node, number 1. Number 2, that in fact the node itself is infected because, they strain bacteria through the lymphatic system, and this one captured a bacteria, but the bacteria said, hey, I kind of like it here. Let's start growing here. And so it starts infecting in the node itself. A primary infection in the node. And the third thing are disorders like that cause systemic nodes to go up, like sarcoidosis or some of the fungal diseases, toxoplasmosis and TB and mono and other things like that. But certainly they're much less common. So the bottom line is that if you have a swollen node that comes in and it may be a little tender, just give them some Keflex, because 2 out of 3 chances is that you're going to do this, or it'll be just fine. And if it doesn't work, they can come back and see in a few days kind of thing. But for the vast majority of them, it's not cancer. You've got a few days to play with it. Here's a bunch of pictures of, I have no idea why I put this in there, bunch of pictures of neck masses. I like the one in the middle. These are the thyroglossal duct cysts. These are embryologically created kind of thing. There's also some on the side that were the bronchial cleft cysts when you were a little frog in your mother's womb. I don't think we ought to do this one here. Ludwigs Angina, you ought to know about. This is about bad teeth. This is infected third molars and stuff like that, causing an infection of all the tissues underneath the tongue. So it's the muscles, the subcutaneous, you name it. And in the process, it lifts up the tongue and moves it backwards. So this is another opportunity for an airway problem, as you could probably anticipate. Ludwigs angina. It's pretty nasty looking stuff. Foreign bodies. Here's the trick on the foreign bodies. You need to take a lateral view. Yeah, you see it on the front AP or PA view really easy. It's a round thing. It's in the trachea, esophagus there. What would the orientation be if it was in the trachea? It would be that way. But it's virtually impossible to find a picture of something in the trachea. They're not really particularly cooperative, as they're gasping for. So all these pictures are esophagus. But the key here is the reason you ought to take a lateral is to see if this is a battery, number one, or if there's a second coin there. The batteries, when they all have a step off. There's one side that is big, and then there's a little step off. If you see the step off, that it's clear that that's a battery. That battery has to be extracted. If it's a nickel, just let the nickel go through, Just watch it a little, it will go down. If it stays there for a while, then you might have to remove it. Dentistry. People come in with toothaches all the time. There's two kinds of toothaches. One is called the periapical abscess. That is the toothache. And apical, you would think, is at the top. Apical. No, the tooth is backwards. The apex is at the bottom. So they got an infection down there, and it hurts like hell, and it's a toothache. And so what are you going to do about a toothache? One of the things you can do is you can inject some marking down around the base of that tooth. That might be helpful in terms of pain. And then you give antibiotics. And the antibiotics that you give for mouth infections, people used to say, well, the matter is penicillin, penicillin, penicillin. Well, the fact of the matter is that these infections, most of the infections of the mouth, involve aerobes and anaerobes. And the anaerobe killers are Flagyl and Cleocin. So the idea of giving somebody Flagyl and penicillin together makes a lot of sense, So I'm not one of these people who's a purist and says penicillin only. No, here's your Flagyl and your penicillin for your tooth infection. And then you're going to go to a dentist kind of thing. The other one is a periodontal abscess. And you know what that one is that you all get these all the time, but they're generally minor. So there's a space between the tooth and the gum, right? Your dentist measures your pockets. Your pockets, oh, it is a 4-foot pocket you got there. So they measure your pockets, stuff gets down there, things get a little calcified down there, a little irritation, you get an infection. Next thing you know, the gum is pooching out, painful. You have an abscess down there. You can deal with that by numbing it up locally and INDing that. That's a periodontal abscess. And the antibiotics are what they are. So here's on the left side picture is, see the gum pooching out there? That's a periodontal abscess. And then the periapical abscess, why is it, what they're pointing to there is that there's gas. There's a gas pocket down there. What is that gas pocket being generated? From anaerobes. Anaerobes generate gas. So that's kind of what they see when they take an x-ray of you. And then they can have their root canal or whatever. Here's a little tooth stuff. Here's the trick question. The trick question is, I'm reimplanting the tooth of a 3-year-old. Knocked it out. I'm going to put that back in there? No. Those are permanent, only you put in permanent teeth. No reimplantation of baby teeth. I don't know how you do it anyway. Hold that in there, Johnny, for about a year, But the loss of the adult teeth, the clock is running. So you get, this survival, 1% loss of survival. So it's quick. You got to be quick. Rinse it off. Don't scrub it. There's a periodontal ligament around that tooth which needs to be there to attach that tooth to where it's supposed to go. So no scrubbing, no dry transport. You don't put it in your pocket. It has to be in some liquid. You can put it in whatever you want, milk. Some people put it in spit, preferably the patient's spit. I need a spit donor. And then you put it in, and one of the issues is how do I hold it in while we're going to go to the dentist? One of the things here they talk about is, well, we don't talk about it. One of the ways to do it is just take a 4-0 or bigger nylon and just go through the gum on one side, over the top of the tooth, and down on the other side, and snug it as best you can. That'll just keep it in place until they see the dentist who will be doing this, that, and the other thing. What happens if they come in and they didn't avulse the tooth, they just broke the tooth? Well, there's two things. One of it is, have I gotten into the center of the tooth, the live part of the tooth? One of the ways you can tell that is, if the center of the tooth is bleeding, you've gotten into the live part of the tooth. If the center of the tooth is yellow, you probably have gotten into the live part of the tooth. If the center of if you put something cold over the tooth and they go through the roof, you've gotten into the live part of the tooth. Or blowing air over it, just taking a breath. It hurts like hell when they do that. They've gotten into the center of the tooth. They need to go to the dentist as quickly as possible. If none of that happens, then the tooth is just kind of like ragged up there, but none of these, there's no evidence of it's gotten into the center of the tooth, and all you need is some kind of grinding it down so that rough edges are there, because as soon as you have these rough edges, the tongue seems to know immediately that there's not something right here and sticks to that and a part of the rough tooth forever kind of thing. So those are the kinds of things for about dentistry. Is there anything else here? No. I think that is the end of the entire course, ladies and gentlemen. I do hope that when you leave, that your passion for emergency medicine will have been stoked, and you want to go back there, and you want to do a good job, and you want to take the new stuff that you learned, and that you will also tell your friends if you're interested in this, because we're going to probably do another one in July. And then Boot Camp 2 is looking for probably around September. And we're going to be emailing you, telling you how to get access to today's talks for those of you who are not here. So I shouldn't be talking to you anyway, since you are here. But that's what's going to happen. We're going to ask for your comments. Now, those evaluations, those are required to be done that way. I think they're absolutely horrible. They rate each lecture, and it's horrible. But that's the way they're required to be done. So when we email you, we're going to say, hey, you got any ideas of what we can do for Boot Camp 2? And you just email us back, and we would appreciate it very much. Thank you all. And I want to thank Diane in particular. Diane is the co-author of all of these lectures. The rest of these guys just delivered them. But they did a great job delivering, I must say. Thank you very much.